Next, we will discuss diabetic ketoacidosis, or DKA. A 42-year-old female drives to the emergency room smelling of booze. She is incoherent and confused. Your first impression is that she is drunk and on drugs. She's lucky she didn't get pulled over and sent to jail for a DUI. Her vitals and labs are as follows: blood pressure low at 90/50, pulse tachycardic at 120. Her respirations are high at 30. Her sodium is 156, normal is around 135. Her potassium is 7.9, normal is around 4. Sodium bicarb level is 5, the norm is 15. Her glucose is 850. The norm is less than 120. Her serum acetone and urine ketone levels are positive. Diabetic ketoacidosis occurs in both type 1 and type 2 diabetes mellitus. Ketones and acetones are elevated because of cell starvation. Hyperosmolar because of elevated glucose levels in the blood. The patient is in a hyperosmolar state, and this causes osmotic diuresis, which means there's loss of lots of free water and some electrolytes. The loss of free water can be severe, and profound hypovolemia and shock can occur. This is our main problem and requires initial aggressive isotonic volume replacement with normal saline, regardless of the electrolyte status. Aggressive volume replacement always mandates continuous electrolyte checks. The main problem is volume replacement. The next problem is protecting the brain, because quick drops in glucose levels and sodium levels can cause cerebral edema and coma. Only a small amount of insulin is required to stop the ketogenesis, acidosis, and feed the starving cells. So remember, dropping glucose levels quickly is actually dangerous. So, after volume replacement, we want to consider insulin. An insulin drip of 10 units per hour is usually enough to stop the ketogenesis. Remember, the brain does not tolerate rapid shifts in osmolarity, so the corrections that we want to make need to be slow. Our next problem is electrolytes. So, we have a sodium of 156. We have a potassium of 7.9. Why would we want to replace these? These are too high. Well, let's take a look at a fish tank. If we take a normal saltwater fish tank and we pour off a third and we remove some of the saline, we let the remaining normal 2/3 evaporate by half, removing free water. Now you have 1/3 the salt water in the tank, but it's very concentrated. If you measure the electrolytes now, they're going to be too high. But if you fill the tank with free water, they will soon be too low. Remember that she has had more free water loss than electrolyte loss. This is why her sodium and potassium levels are elevated, or at least appear elevated. When the free volume gets replaced, the potassium, the phosphate, and the calcium concentrations can drop, and this can be lethal. So, the bottom line in DKA is that boozy breath may mean DKA. Problem number 1 is volume. A few liters of normal saline bolus to start. You may want to switch to D5 and half normal saline with 20 milliequivalents of potassium phosphate later. Glucose correction needs to be slow and gentle. An insulin drip of 10 units an hour will feed the cells and stop the ketogenesis. The electrolytes must be checked hourly. Bicarb when initial pH is less than 7 or the patient has overwhelming acidosis. Potassium phosphate may be a replacement. This can be done with D5.5 normal saline plus the 20 milliequivalents of the potassium phosphate. The patient may need a calcium bolus, and this would be in the concentration of 1 amp of calcium gluconate. We're going to talk shortly about hyperosmolar, hyperglycemic, nonketotic syndrome. That's a lot of words, so we're going to just break it down. Hyperosmolar means that there's an increased osmolarity in the blood due to increased blood sugar. Hyperglycemic means high blood glucose, usually greater than 400. Nonketotic means that there are no ketones in the blood or the urine because there is enough circulating insulin to keep the body from breaking down fat and protein for energy. So, management of both DKA and hyperosmolar, hyperglycemic, nonketotic syndrome is pretty much the same. We want volume replacement. We want to monitor the blood glucose. We want to monitor the electrolytes and replace them after volume replacement. We want to monitor the intake and output and the renal status. It's also important to monitor the cardiac status of these patients because of our fluctuating potassium levels. Pulmonary function is also important due to the increased respirations while the patient is trying to blow off CO2. Level of consciousness is always an important monitoring of our patients. And of course, we want to monitor the patient's vital signs. So, it's also important to note that some medications or substances are known to affect the blood glucose levels. And these include corticosteroids, estrogen, lithium, phenytoin, thyroid preparations, some potassium-depleting diuretics, and large quantities of caffeine. Next time, we will talk about the posterior pituitary, SI-ADH, DI, and the anterior pituitary.